Thank you for joining us here today. I'm Fabiana Bacchini, Executive Director of the Canadian Premature Babies Foundation. CPBF is a charitable organization, and our mission is to empower families of premature babies through support and education. This Premi Chat series is one of the many initiatives we have to bring information and education for NICU families and healthcare professionals. Here, every Friday, we talk with experts, researchers, and parents who share with us their experience and knowledge. Also, on our website, canadianpremis.org, parents will find all kinds of resources and support. And today we're going to talk about the preterm brain injury. In this presentation, Dr. Selvanathan will be reviewing the different types of brain injury in preterm babies. Let me bring her here on our live streaming. And Dr. Selvanathan is currently a neonatal neurology fellow at SickKids and is completing a PhD in neonatal neuroscience at the Institute of Medical Sciences under the supervision of Dr. Stephen Miller. Her research uses advanced brain imaging methods to study the links between brain injury and clinical factors, specifically how we treat pain in babies. Dr. Selvanathan, thank you so much for joining us live from Toronto today. I'm so honored to have you here with us, sharing your expertise and giving information to families of premature babies.
Thank you so much for having me today. I've really been looking forward to joining you this afternoon. And we'll be talking about an important topic, preterm brain injury. And I'll be sharing my perspective as a pediatric neurologist. And I look forward to hearing your perspective and the parent perspective in the Q&A session.
That is wonderful. Yes, so you can start sharing your screen. And for all of you watching us live today from Facebook or YouTube, please do send your questions, your comments. We're going to address them at the end of her presentation. And if you are watching on Twitter, I will try to monitor the Twitter comments and bring your questions as well to Dr. Selvanathan. Okay, I'm going to bring your presentation here and you can start.
All right, thank you very much. And thank you very much for joining us this afternoon. We're going to be talking about an important topic in preterm babies, which is preterm brain injury. And specifically today, the focus of my talk will be on two types of preterm brain injury. We'll start off by talking about white matter injury, and we'll review some pictures of what this looks like and also what this means for a child's future. And we'll also talk about interventricular hemorrhage, which is another common type of brain injury in preterm babies. So before we talk about white matter injury, I think it's important for us to review some of the key structures in the brain that we're looking at. So here on the left side of this slide, we have a picture of the brain. This is taken in what we call an axial section. So it's taken through the brain this way. And we have the two sides of the brain here, the left and the right side. And here in this picture, you could see that the brain has some different colors. We're going to start off by looking at the outside of the brain. This is the darker brown, lumpy, bumpy part of the brain here. And we refer to this part of the brain as the cerebral cortex. And this is where the neurons of our brain, one type of brain cell, live. We also have these darker brown structures deeper in the brain. So here we can see these darker brown structures, and these are deeper structures in the brain where neurons also live. And collectively, these structures where neurons live is called gray matter. You can see that in between these darker brown structures, we have some lighter white regions. And this is what we call white matter. And this looks white because we have something called myelin that covers all of these fibers, and that's made up of fat, which gives it a white color. If we look at the white matter, here on the right side, we have a picture of what this looks like. And it consists of a whole bunch of fibers that are connecting these gray matter regions. We have fibers that are connecting the two halves of the brain. We have fibers that are connecting the front part of the brain to the back part of the brain. And we have fibers that are connecting the different gray matter structures to each other. So from the cortex to the deeper structures, and also from areas within the cortex to each other. And so the white matter contains a lot of important connections that connect different regions of the brain to each other. And so now we'll go on to talk about white matter injury. And this is a term that encompasses a few different types of brain injury. The first is what we call cystic periventricular leukomalacia. And here we have two pictures of this. On the left side, we have a picture of this on a head ultrasound in a baby. And this ultrasound is shown in what we call a coronal section. So we're taking the ultrasound probe and we're looking down on the brain. This is the top of the brain, and this is the bottom of the head. And we're taking what we call coronal sections, meaning going down this way. We have this darker region here, this black region, which we call the ventricles. And this is a fluid-filled space in the brain, and we'll come back to this region. Then here we have the lumpy, bumpy cortex, and in between we have the white matter. And you can see here, when you look at this white matter, you see these little cystic areas, and they're cysts because they're cavities that are filled with fluid. And because it's fluid, it's also black, like the fluid that we see in the ventricles. So this is a picture on a head ultrasound. We're now going to look at this on an MRI. So here, once again, we're looking at the top of the head here, the bottom of the head here, and looking at coronal sections this way. This is the left side of the brain and the right side of the brain. This part here on the MRI, the fluid-filled space, the ventricle looks white because fluid is white on this MRI sequence. And here we can see in this white matter that we see these small cystic areas, that is cystic PVL. And in the past, we used to see more cystic PVL. However, with the advances in how we care for babies in the NICU, it's much less common now for us to see this type of white matter injury. And the type of white matter injury that we see more commonly now is a type that we call punctate white matter injury. This type of white matter injury is not well seen with head ultrasound, and we see it much better with MRI. So here we have a picture of a preterm baby who had an MRI. We're now looking at axial sections of the brain that go this way. This is the left side of the brain, and this is the right side of the brain. This is the front, so this is where the baby's nose would be, and this is the back of the head. Here, these darker spaces are where the ventricles are. This is the cortex, the lumpy, bumpy part of the brain, and in between we have the white matter. And you can see here in the white matter that we have these small white dots. And these white dots are what we call punctate white matter injury. And you might see that sometimes we refer to white matter injury as mild, moderate, or severe in terms of our severity. And here we have examples of what this would look like on an MRI. So in the first image, we have an image of mild white matter injury. And here you could see this one little lesion over here. Here we have an example of moderate white matter injury. And here you could see that there are a few lesions in the white matter. And here we have an example of severe white matter injury, where you start to see more lesions in the white matter. And so an important question is, what does this mean for my child? That's often what we're asked by parents. And so if we look at children as a group overall who have cystic periventricular leukomalacia, overall as a group, infants with cystic periventricular leukomalacia may be at risk for spastic diplegic cerebral palsy. And it's spastic diplegic cerebral palsy, meaning affecting both of the lower limbs or both of the legs. And this is because of the location of the lesions. And so here we're looking at a cartoon picture of the brain, once again in a coronal section. So meaning we're going down the brain this way. And here what these lines show are the white matter fiber tracks that carry information about different parts of our body down into the spinal cord. And here you could see that there are tracks for the legs, for information about the legs, that are passing around the ventricles. Those are the tracks that pass closest to the ventricles. So when we have cystic PVL, so here on the MRI, and shown in yellow on this cartoon, what happens is we have lesions in the white matter that are closest to the ventricles. And because the leg fibers are closest to the ventricles, we see that it preferentially affects the fibers that are going to the legs. When these lesions are more extensive, they can also impact the fibers carrying information about our arms and can also be associated with spastic quadriplegic cerebral palsy. When we talk about white matter injury, lesion location is also important. And in this study, what they did was they looked at the MRIs of preterm babies who had white matter injury and looked at whether the location of these punctate white matter injury lesions were associated with their neurodevelopment. So what they did was they drew a line that passed through the middle of the ventricles to look at where these lesions were. And in babies who had lesions posteriorly, so towards the back of the head, which is here, towards the back of the head, what they saw was that these lesions were not associated with cognitive outcomes. However, when they looked at whether these lesions that were located more anteriorly, so towards the front of the head, as you can see here, what they saw was that anterior lesions were associated with a higher risk for cognitive and motor difficulties. And so we've now spoken a little bit about white matter injury, and we'll move on to talk about intraventricular hemorrhage in preterm babies. And in order to understand this, it's important for us to start by reviewing the anatomy of the ventricular system. So here we have two figures. We're going to start with this figure here on the left. We have two red structures, and these structures represent the lateral ventricles. And then we have these structures that are shown in pink. In the middle, we have a structure called the third ventricle, and here at the bottom, we have the fourth ventricle. And the ventricles are all connected to each other. And here, if we look at this image on the right, you could see that there's a structure that's in pink. And this structure is called the choroid plexus. The choroid plexus lines the walls of these ventricles and produces cerebrospinal fluid. And cerebrospinal fluid is constantly being produced by this choroid plexus, and it flows through the ventricular system. And you can see how this flows by the arrows on this diagram. And as the choroid plexus is constantly producing CSF, this is also, or CSF or cerebrospinal fluid, this is also being reabsorbed by structures around the brain so that we always have a good balance of cerebrospinal fluid and we don't have a buildup of it around our brain. So intraventricular hemorrhage occurs in about 40% of preterm babies. And when we talk about intraventricular hemorrhage, an important structure for us to discuss is a structure called the germinal matrix. And this is a transient or developmental structure because we only see it for a period during brain development. This structure is shown here in yellow on this diagram, and you can see that it's really close to where the lateral ventricles are, which is shown in purple on this diagram. And the structure is very important because it generates neurons and glial cells, which are support cells in the brain, until about 25 weeks gestation. And then slowly the structure gets smaller and smaller and it disappears by term. And this is why we see that IVH is more common in babies who are born at earlier gestational ages. And we can see this here if we look at this figure that shows the percentage of babies who have germinal matrix and intraventricular hemorrhages that's plotted by gestational age. And what you see is that the percentage goes down with increasing gestational age. And so intraventricular hemorrhage is more common for us to see in babies who are born at earlier gestational ages. And when we talk about IVH, we can talk about it in terms of its grading. And here we have some head ultrasound images that were all taken in the sagittal plane. So here they're taken down the middle of the head, and these show different grades of IVH. So we're going to start with the first one. So when we have a grade 1 IVH, what this means is we have a germinal matrix hemorrhage, or hemorrhage that takes up less than 10% of the ventricle. So here we have a picture that's taken down the middle through the sagittal plane. We have the ventricle here, and this is shown in this block structure. And you can see this little white arrow is pointing to this small, bright white dot. And this represents a germinal matrix hemorrhage and is a grade 1 IVH. In the middle, we have an ultrasound that shows grade 2 IVH. So in this, we have intraventricular hemorrhage, where blood is taking up between 10 and 50% of the ventricle. So we have the ventricle shown here again, and you can see how there's this bright white area over here, and that represents blood or hemorrhage that's within the ventricle. And you can see that this takes up less than 50% of the ventricle. And so this is grade 2 IVH. And then here in the last image, we have an example of grade 3 IVH, where we have intraventricular hemorrhage that fills up over 50% of the ventricle. And so we have the ventricle that would be over here. And you can see how there's this white hemorrhage, and that takes up more than 50% of the ventricle. So this is grade 3 IVH. And in the past, you may have heard of the term grade 4 IVH. However, we now refer to this as periventricular hemorrhagic infarction. And we'll talk a little bit more about this in detail today as well. So here we have an example of periventricular hemorrhagic infarction. And this can be a complication that's associated with intraventricular hemorrhage. Another complication that we can see that's associated with it is called post-hemorrhagic ventricular dilatation, or PHVD. And we'll go through some images and talk about this in a little more detail today as well. So we'll start off by talking about PVHI. So this is periventricular hemorrhagic infarction. And we'll start off by reviewing the mechanism, or why this happens. So PVHI is associated with IVH in preterm babies. So what happens is you have bleeding that occurs within the ventricle, and then the bleeding can compress a vein that kind of drains the blood from this part of the brain. What happens is when there's that compression, it increases the pressure in the vein because you have congestion within the vein. And when it increases that pressure and causes this congestion, it can lead to bleeding from the vein into the surrounding brain tissue. And so here we have examples of this on a head ultrasound in the middle and on a brain MRI on the right. So we'll start by looking at this on the head ultrasound. So this is a head ultrasound. This is the top of the head. This is the bottom of the head. And it's taken in the sagittal plane. So we're going down the middle like this. And here is the ventricle. And here this arrow is pointing towards this white part here. And this is an example of PVHI. We're now going to look at this on the MRI. So here is an MRI that was taken in a preterm baby. Here we have the top of the head. We have the bottom of the head down here. And the MRI is in a coronal plane. So we're going like this. Here we have the ventricles, which are in white. This is the left side and this is the right side. And you can see that the right side looks a little bit different from the left side because we see this over here. And this is an example of PVHI. It usually affects the white matter around the ventricle. It's usually on one side and it has this kind of triangular shape. The other complication that can be associated with intraventricular hemorrhage is post-hemorrhagic ventricular dilatation, or PHVD. And this happens because of essentially what happens is we have a block of flow, or the absorption of the cerebrospinal fluid is affected. after IVH. And what this does is it leads to dilation of the ventricles. And here we have some examples of what this looks like on a head ultrasound. So we'll start off by just looking at what normal ventricles would look like. So here is an ultrasound. This is taken through the coronal plane this way. Here's the top of the head and the bottom of the head. And these are the ventricles over here. And you can see what they look like in terms of size on this image. On the right side, we have an example of PHVD, where we have dilatation of the ventricles. Once again, this is also in the coronal plane, so this way. This is the top of the head and the bottom. And the dark structures, the dark regions, are the ventricles. And you can see here in this image that the ventricles are much bigger, or that they're dilated. And so this is an example of what PHVD would look like on a head ultrasound. So when we talk about neurodevelopmental outcomes in intraventricular hemorrhage, there are a few important factors for us to consider. One is the grade of IVH, and mild IVH, or grades 1 and 2 IVH, in these babies, what we see is that neurodevelopmental outcomes may be similar to babies who don't have IVH. And really, neurodevelopmental outcomes in this group is influenced by the presence of other types of brain injury, such as white matter injury. When we talk about grade 3 IVH and PVHI, we see that overall as a group, these babies have a higher incidence of motor and cognitive difficulties. And the motor difficulties can be related to the location of injury, particularly with PVHI. And so here's an example of an MRI where we have a baby who has PVHI. And in PVHI, babies may be at risk for spastic hemiplegic cerebral palsy. And this is, once again, because of the location of the lesion. And so here we have a cross-section of our brain. We're only looking at half here in this image. And so once again, we have those white matter fibers that are taking down information about different parts of the body. And we have the fibers for the leg, the trunk, the arm, the face, and so on. And here, this is where the ventricle is. And this blue area represents the area of PVHI. And so in PVHI, what happens is we have fibers that affect the information about the leg and the arm on one side of the brain. And so what happens is we see symptoms on the opposite side of the body that affect the arm and the leg. And so these children may be at risk for spastic hemiplegic cerebral palsy. However, it's important to remember that not all babies with PVHI develop cerebral palsy. And so here was a very important study where they looked at the association of PVHI with neurodevelopmental outcomes. And here we're looking at the percentage of babies with unilateral PVHI, so PVHI on one side of the brain, versus bilateral PVHI, so PVHI on both sides of the brain. And you can see here that not all babies develop cerebral palsy. And so there is a lot of variability in outcomes, and this is also where lesion location may matter. So for example, PVHI that occurs in the frontal lobe may be less likely to be associated with cerebral palsy. And so lesion location is important, and there's a lot of variability in outcomes. The other complication that we can see with IVH is PHVD, and this is where early intervention may be very helpful in promoting neurodevelopment in babies who have PHVD. So here there was a study where they looked at the approach to treating PHVD in babies who had this, and they had two groups of infants. One group of infants where they used an earlier approach, where they did routine head ultrasounds, measured the size of the ventricles, and intervened early without waiting for symptoms to develop. In the later approach, they did head ultrasounds, but they intervened when there were symptoms and signs suggesting that there was the ventricles were getting quite big and the children were becoming very symptomatic. And so this is shown here as the early approach group and the late approach groups in each of these panels. And we have the cognitive outcomes in these babies and the motor outcomes in these babies in panels A and B. And when we look within each panel, what you'll see is it's broken up into two. And these are babies who were in the early approach group who did not need any interventions, and those in the early approach group who did need interventions. And similarly, these are broken down into kids who didn't need interventions and those who did, and so on. So we're going to start off by focusing on the early approach group. And so if we look at cognitive and motor scores for babies in the early approach group who did not and did need interventions, what we see is that the cognitive and motor outcomes are very similar. However, if we go on to look at the late approach groups, so here we're looking at the right side of each of the panels. This is the cognitive outcome scores. These are the motor outcome scores. If we look at babies who did not need any intervention compared to those who did, we see that the babies who ended up needing intervention, who had it late, had lower scores compared to those who didn't. And so this suggests that for babies who have PHVD who need interventions, earlier interventions may be associated with better neurodevelopmental outcomes than later interventions. And so we've spent some time reviewing what the imaging features of white matter injury and IVH look like today. And so what's important is that we do routine brain imaging in preterm babies, as brain injury in preterm babies is usually asymptomatic. So babies don't usually have symptoms. And so it's important for us to identify brain injury early so that we can monitor and provide interventions that support brain development. And here this slide summarizes the Canadian Pediatric Society guidelines for brain imaging in the preterm brain. And as you can see here, head ultrasound examinations are recommended for all babies who are born less than 32 weeks gestation within the first week of life. And this is done to detect intraventricular hemorrhage and early ventricular dilatation. If these head ultrasounds show IVH is grade 2 or higher, then you repeat head ultrasounds fairly frequently to look for progression and potential complications like post-hemorrhagic ventricular dilatation. They also recommend, you can see here, repeat imaging around 1 month after birth because PVL, cystic periventricular leukomalacia, is better seen at this time point. And although routine MRI is not recommended for all babies, it should be considered in babies who are born before 26 weeks, or when there are clinical risk factors for brain injury, or if there are changes that we see on the head ultrasound that we want to look at in more detail with MRI. And so we've spoken about brain injury today in this talk. However, I think it's important that we expand our focus on the brain to look more widely at long-term brain development. And here we have brain MRIs from a baby who had 3 MRIs. The first MRI was done early in life, close to when this baby was born, around 30 weeks gestation. The second MRI was done around term age when this baby was 39 weeks. And then this child came back for follow-up and had an MRI when they were 8 years old. And you can see how much the brain has changed over the years. And so if we look at the brain, you can see that it's grown in size. If we look at the gray matter, so this here is the dark region, this kind of ribbon over here, you could see how it goes from being smooth early on to more lumpy and bumpy, which we see here at term and also at 8 years of age, where the cortex is quite lumpy and bumpy. And if we look at the white matter, we actually see that the color of it changes. And this is because of changes in white matter development and the formation of what we call myelin. And so here, the white matter is quite bright. Here we start to see some areas that become darker. And here you could see that the white matter is dark. It looks very similar to what we would see if we did this MRI in an adult. And so there's a lot of changes that are happening in the brain over time, both while the baby is in the NICU and also after the baby goes home and is at home with you. And so it's important for us to think about how we can promote brain development to promote neurodevelopmental outcomes in babies who are born preterm. And in the NICU, our everyday practices, such as how we treat pain, how we ventilate babies, providing nutrition to babies, these are all important in promoting optimal brain health in babies who are born preterm. And an example of this is brain care bundles. And many NICUs have developed these brain care bundles that are performed for the first 72 hours of life in very high-risk babies. And this is done with the goal of preventing big changes in blood flow, which can increase the risk for brain injury. And some of these strategies include midline head positioning, so keeping the head in the midline, elevating the head of the bed to 30 degrees, and minimizing pain for these babies. Another very interesting point is the importance of the home environment. And socioeconomic status in particular might modify the associations that we see between brain injury and neurodevelopmental outcomes. And here, this very interesting study studied these associations. And so if we look at this graph, we see IQ scores at 18 months, 36 months, and 4.5 years for babies who were born preterm. And if we look at the colors of the lines, these represents 3 different groups of families. Families with moms who completed primary or secondary school, with moms who completed undergraduate degrees, and moms who completed postgraduate degrees. And in this study, they used maternal education as a marker of socioeconomic status, because that was what was readily available. However, we would have observed the same findings if we used other measures of socioeconomic status, such as income or even paternal education. And so the colors of these lines represent these different groups. And the kids who have brain injury are shown by the dashed lines, and kids who don't have brain injury are shown by the solid lines. And what you see here is that overall, children who are born to mothers with greater maternal education had a higher IQ scores overall. However, what's very interesting is that the association between brain injury and neurodevelopmental outcomes was moderated by socioeconomic status, in the sense that for babies who were born to moms with a postgraduate education, the cognitive scores were not different in babies who did and did not have brain injury. And you can see this because the solid and the dashed lines are overlapping. And so it's important for us to identify the differences in the home environment in these families. What's different about the care that these children are getting, so that we can try to implement these strategies in other families to improve this gap in outcomes between babies with and without brain injury. So through my talk today, we've discussed different types of brain injury in preterm newborns, including white matter injury and interventricular hemorrhage. Both of these are common in preterm babies and may be related to neurodevelopmental outcomes. However, from my training and experience seeing children back in follow-up, I've realized that every child and family is different, and there's a lot of variability in outcomes in preterm babies who have brain injury. And a lot of research is focused on understanding what factors contribute to these differences. It's also important that we expand our focus from brain injury to promoting brain development and neurodevelopment in preterm infants through the ways in which we care for them in the NICU, but also through the ways in which they're cared when they're at home with you, with their families. So thank you very much for listening. And I'd like to give a very special thank you to all the children and families who participate in our research studies, who often come back for multiple follow-up visits, multiple MRIs. Our research study certainly would not be possible without you. I'd also like to thank my many mentors at SickKids and across Canada for their support with my training and my research. And I'd be happy to take any questions that you have, and I'd also be very interested in hearing your perspective on this topic.
Okay, Dr. Selvanathan, thank you so much for your presentation. I wish every ICU had one of you to explain this to parents in such a way that we can understand this medical terminology, the images. It was amazing. Thank you so much. So we have a few comments here that I'm going to bring on the screen. And I just want to say hi to our live audience. We have Leah from Halifax. We have people from St. Thomas and different parts of Ontario. So thank you all for joining us here today. So my first question is, you mentioned that 40% of the preterm babies can have IVH or have IVH. Is the risk higher according to the gestational age? So the lower the gestational age, the higher the risk of IVH, or different grades of IVH?
Yes, that's definitely correct. So we see that the highest risk is in the babies who are born at the earliest gestational ages, and this is related to development of the germinal matrix. So it's really the younger babies who are at highest risk.
Okay, so comment from Laurie. Hi, Laurie. Laurie is in Northern Ontario, in Kenora. Very interesting presentation. My 32-weeker had grade 4 IVH and several punctuate lesions in his white matter. He was diagnosed with hemiplegic cerebral palsy in the fall. He's doing well and will turn 2 next month. Thank you so much for sharing that with us, Laurie. So a question in relation regarding the white matter, because the white matter, it's something that is not really seen on head ultrasound and babies are in the ICU. So how early can we, as parents or an ICU, can recommend parents to start early intervention, knowing there is a risk, but we cannot see on a head ultrasound?
So I think that with white matter injury, like you mentioned, the changes are not, the punctate white matter lesions are not appreciated on head ultrasound. In terms of early interventions, I think that the most important thing is being connected to a good neonatal follow-up clinic, coming back to see the neonatal follow-up team early and regularly, kind of every few months in the early part of life, so that we can see if there are differences in, the movements that babies have, or if we're seeing differences in their development, so that they're connected to the appropriate developmental supports, the occupational therapists and the physiotherapists, as early as possible. And then I think as parents, a lot of what you can do is talk to your baby, read to your baby, play with your baby. These are all important things that help support your baby's development at home. And so these are things that you could do at home even before you start seeing the neonatal follow-up team.
Okay, thank you. So I have another question here. Sorry, would brain injury explain increase of incidence of autism among very preterm babies? I'm sorry, need some water here. Can you see the question there?
Yes, I can. So it looks like the question is, would brain injury explain the increase of incidence of autism among very preterm babies? So that's a very interesting question. There is not a lot of literature focusing on the incidence of autism and relating that to brain injury. And that's definitely an area of research that requires further focus. There's also a lot of literature looking at brain development, kind of apart from just brain injury, brain development and autism. And so that's a great question. I think it's something that we need to study further because we don't have a great understanding of how brain injury contributes to autism in preterm infants.
Okay, that is great to know. And for sure, there's many areas that we can absolutely improve. So there is one more comment here. From Laurie, we had an MRI before an ICU discharge due to abnormal ultrasound and several platelet transfusions. Follow-up didn't happen until my son was 1 year corrected due to being in Northern Ontario. Well, I think that is a huge discussion that we always talk about, the families who are actually in the big center versus the families who live in more remote areas, far from big centers. So what is your take on it?
No, that's definitely a very, like you mentioned, it's a conversation that keeps coming up, that, you know, the access to care is different kind of depending on where you live. And this is definitely something that I think we need to work on. And part of it may be, you know, through people like you and advocating for that, so that we have changes to how we care for preterm babies, so that all preterm babies, regardless of where you live, are looked after in the same way.
Absolutely. We know there's a lot of work to be done. Canada is a big country geographically, right? And you know, all the big centers, families have resources, and especially during COVID, a lot of families couldn't access those resources because they live far, and a lot of appointments got canceled, or online appointments that made families' life really, really difficult during this time. So that leads to my question in terms of early intervention, because you mentioned about early intervention, what can be done earlier on in life. I mean, the family can go to a follow-up appointment, but if there is not as much access to follow-up appointments at this time during COVID especially, what can they do to support this brain development, to promote brain development?
So I think some of the strategies that families can do at home, especially early on, are tummy time, reading to your baby, playing with your baby. So these are things that all support your child's development. But I think an important piece you brought up is advocacy, and advocating for your child, and advocating for children who live further away from academic centers. And I think that you're doing really great work through your group, doing that as well. And I think we need more of that.
Thank you. Yes, I feel that there's a lot of conversation that have to continue to happen in the ICUs, and linking to resources in the community, because there's a lot of, it's so overwhelming when you go home, right? You have to make sense of what happened in the ICU, the prematurity, birth, the preterm birth, and then you go into the community, you don't even know which resource you have available. So I think that is something that we have to continue working on, to support babies who are at high risk. So my question also is in regards to neuroplasticity. If babies have IVH, and it was, you know, you could see on a brain ultrasound in the ICU, can that be repaired? Because we know there's so much conversation around neuroplasticity and what you can do to provide a better support for the babies. So what happened there?
So that's a really great question. So there have been various kind of treatments that are under investigation. For example, erythropoietin was one, more for neuroprotection, and stem cells is one that's being investigated for neuroprotection and also neurorepair. As so far, these strategies are not yet implemented clinically because they're under investigation. So they're still in research trials and animal models, and I believe there's a clinical study as well of stem cells. And so hopefully in the future, in the upcoming years, we'll have a better understanding of whether this is helpful in, like you said, in promoting neuroplasticity and also repair after brain injury. So this is definitely a big area of research that a lot of people around the world are looking into. And hopefully in the next little while, we'll have some good answers and some potential strategies.
And so there's a lot of hope for the future. We have talked to Dr. Miller a few times about what is new and upcoming as well in research. And there's a comment here from Catherine. Thank you so much for actually talking about singing, dancing, and using music that can support brain development and family bonding. So that there is so much conversation around music, right? Music therapy. There's a music therapist in the NICUs. At least before COVID, there were music therapists inside some NICUs. Talk to us a little bit about music. How does music help the brain? Or at least in my case with my son, I used to sing to him in the NICU with my terrible voice, but he loves and he loves to sing. So talk to us about this piece of art that can help the babies.
So in terms of, I have to admit, I'm not an expert in the brain changes that are related to music, but it's like you mentioned, music, talking to your baby, this can promote, the parent and infant bond. And so these are really important in supporting that relationship and promoting brain development and neurodevelopmental outcomes. So it's something that you can do at home with your baby and also in the NICU, singing your baby, holding your baby. These are all things that promote their development.
Absolutely. So now let's talk a little bit about delivering news to parents, because when you talk about the brain, this is one of the scariest things that we can hear in the NICU, that your baby has a brain injury or a brain bleeding, and what it means to life of the families and the babies, how the future looks like. So I want to discuss with you a little bit on that, because every now and then families come to us that the baby was diagnosed with cerebral palsy while the baby was still in the NICU. Sometimes I wanted the parents hear, well, what they understood from that conversation. But I also want to hear your perspective on giving this kind of news to parents in the NICU and how it's going to look like in the future. Because we had a lot of conversations, do an MRI in the NICU, don't do an MRI in the ICU. That wouldn't change the outcome, or that might help families with earlier intervention. I just want to hear your perspective on that.
Sure. I think this is a topic that comes up often, brought up by parents, also brought up by my mentors at SickKids. And this is definitely a focus of our training program. And I think that my perspective of these conversations has definitely changed over the years as I've gone through my training. I think that in some ways it's challenging in that we want to make sure we give you information that's accurate, so that you can make well-informed decisions about your child and for your family, so that you can support your child and also make plans for your child's future. However, it's important to do this in a way that doesn't necessarily, take away hope. Mm-hmm. And I think that balance between the two can be very challenging. And I think this is also kind of mixed in with the fact that sometimes these conversations are happening the first time we meet with you. It's the first time that you're meeting a neurologist in the NICU in a very stressful period during a very stressful time in your life, when you've had a baby early, much earlier than you probably expected to. And so I think what I've realized is what's helpful is often having these conversations over time and getting to know the children and their families over time, and having these conversations over time. And also being able to see kids in follow-up and seeing how they do over time is also helpful, because it gives us a sense of how a child is doing over time. Because there's a lot of variability in how children with brain injury do over time as well. So I think that would be my perspective. I'm very interested in hearing your perspectives on this as well. It's definitely an issue that comes up often, and I think that it's something that we all will definitely need to work on, and I'm sure that I personally will continue to work on this throughout my career.
Absolutely. This is such sometimes I find like a difficult topic to talk about, because parents, my son has quadriplegic cerebral palsy. And if I go to talk to a family in the NICU, they don't want to hear that, right? Because they fear the outcome will be the same as that, because, what CP means to a family, to the child, and my son is 9 years old now, and that is not a death sentence. My son brings so much joy to us. And this is what I always try to tell families, like, the diagnosis is just a label. Like your child, you love your child unconditionally. It's not an easy life because you have to to have a lot of appointments, and it is an overwhelming life, but it's a life that none of us parents with kids with special needs or disabilities would trade, because the children bring us so much joy. But it's a hard conversation, because when you're in that ICU, you don't want to hear a possible outcome that is not what you were expecting. Mm-hmm. So I think it's always like, what is important for families to know at that point. Yeah, but it is definitely difficult, right? And my son's diagnosis came when he was almost 2 years old. Obviously, we knew he was late because I was a second-time mom. I knew being preterm, he could be delayed. So I was very proactive, but the diagnosis really came when he was almost 2. And it was devastating in the beginning until we learned what it means to us. And I think having great doctors on your team it really helps on the journey. And I'm super grateful that Dr. Miller was the neurologist caring for Gabriel that time. So we had a good start on the right direction, or what we could do for him. But Dr. Selvanathan, thank you so much for joining us here today. So great talking to you, learning from you. And I hope you come back, because your presentation was excellent. I'm sure families will enjoy for a long time to learn from you, because you explained so well and so clear to all of us who don't have a medical degree. So thank you for that.
Thank you so much for having me. It was a pleasure joining you this afternoon.
Okay, and for all of you watching us live here today, thank you so much for joining us on our Facebook, YouTube channel, or Twitter. The video of today's session and all the videos from our live sessions are pre-recorded and available on our website, which is thecanadianpremise.org. I also want to thank our sponsor, AstraZeneca, for their ongoing support to our education sessions. And we are a charitable organization, and we believe that through support and education, we can empower families, ensuring they are ready to care for their babies. Visit our website, consider making a donation. Together, we can create a brighter future for all our families. And I see you again next Friday, 1 p.m. Eastern Time. Stay well.